Great. So thank you, Norman. It's a great honour to be here. Thank you for inviting me to come and speak. So what I'm going to do is talk to you about the relationship between vascular disease in the brain and dementia, some of the epidemiology, how we try to classify these disorders, a little bit about post-stroke dementia, because any classification system for vascular dementia has to include people who develop insidious cognitive decline related to vascular disease, but also people who develop dementia after a stroke. And these are kind of slightly separate, as you'll see, but they have to be incorporated into a single classification system, which is difficult. I will then talk specifically about subcortical small vessel disease, which is a very, very important topic. A little bit about CADASIL, and then at the end, if there's time, we'll talk about what we know about the prevention and treatment of vascular dementia, which unfortunately is not a lot. So first, the good news. Stroke in high-income countries is getting less common. So this is some data that was published in Lancet Neurology about 10 years ago now, dividing studies up by epoch, and I think, again, it doesn't project very well, but on the furthest left, you've got studies from the 1970s, then the 1980s, then the 90s, and then the noughties. And it looks as though, at least in high-income countries, stroke is declining in incidence. So that's very good. And in fact, dementia prevalence is falling as well. So this is from CFAS, which is probably the best UK-based epidemiology that we have for dementia. And there are two sampling epochs here. The blue columns are from the early 90s, and then when they went back and had another look in the early noughties, in the late noughties, as you can see in the orangey bars, there's clearly been a reduction in the prevalence of dementia. And maybe these two things are linked. There's less vascular disease and less stroke. Maybe that's why there's less dementia. Because we don't actually know why dementia is falling in England, but better control of vascular risk may be one of the reasons. Improved rates of education is the other possible hypothesis. Now, this is data from America just to show you that the fall in dementia prevalence isn't only seen in the UK. So if you look just at the red bars, which is dementia, blue is mild cognitive impairment, and you just compare in each, it's done by age groups. On the far left, we have people aged 65 to 74, and then we have each pair is a decade of life. And if you look, you'll see that the red bars, the first of the red bars is the prevalence in 2000, and then the second of the red bar in each pair is the prevalence in 2012. You can see in every age group the prevalence of dementia, and indeed, if you look at the blue bars, the presence of mild cognitive impairment, the prevalence of these disorders is declining over time. So that's all the good news. Unfortunately, that is the end of the good news, because if you look at the same cohort that was published in that American study, and you look and you compare the 2000 cohort and the 2012 cohort, look at the rates of diabetes in the 2012 cohort compared to 2000. Okay, it's gone from 16% to 25%. Look at the rates of hypertension. They've gone from 55% to 67%. Look at the rates of obesity. So people with a BMI of over 30 now are 30% of that cohort. So I think that the danger we've got is that we've done something right to reduce dementia prevalence. But if we think that that is related to better control of vascular risk, we are sitting on a ticking time bomb in terms of the increasing prevalence of significant vascular risk in the population. And that's why in the abstract, I think we've got to be concerned that this decline in dementia prevalence may be reversed if these risk factor trends persist in the population. And just to show you, this is from the Whitehall study, and this was published in the BMJ just about 3 weeks ago. It's a very nice, like all the Whitehall studies, large-scale kind of cohort study. And what it shows is that they divided, so as you may know, the Whitehall study and Whitehall 2, they're based on civil servants. And they were divided up into 14 groups based on their cardiovascular health score. So down at the end, number 1, that's the most unhealthy group, so with all the vascular risk factors you can think of, obesity, smoking, hypertension, etc., low rates of exercise. And after following them up, what they've plotted here is in the top half of the graph is the presence of the risk of the hazard ratio for dementia at the end of the period of observation. You can see that if you are in group 1, which is the most unhealthy group, we can be 95% sure that your hazard ratio for dementia is at least twice that of people in the kind of the median group, which is group 9. So there's very little doubt that vascular risk correlates with dementia risk. And this is just looking at that in, again, a slightly awkward graphic, but showing, so if you look at each of the columns going down, the first column is vascular dementia, the second column is post-stroke dementia, the third is sort of dementia unspecified, so studies where we haven't got a subtype, and the fourth is Alzheimer's disease. And then across and down we have all the different risk factors. And you can see that most vascular risk factors increase your risk, obviously, of vascular dementia, and clearly also increase your risk of Alzheimer's disease. So these things are closely related. One of the things that's unfortunate is that actually there's a lot of, for things that are vascular risk factors, there are more known unknowns for vascular disease, vascular dementia, than there are for Alzheimer's disease. So vascular dementia, whatever it is, and we'll come in a minute to try and work out what it is rather under-researched in terms of risk. And I think that comes to an important question about how much dementia is vascular dementia. For Dementia UK second edition, which was published by the Alzheimer's Society, I think it's about 4 years ago now, a group of experts were asked through a sort of Delphi consensus to try to tell us what we think the subtype prevalence is based on looking at different types of study. And they came up with the figure that Alzheimer's disease is about 2/3 of dementia, and pure vascular dementia is about 15%, and mixed dementia is about 10%. Now, unfortunately, I think that this may be an oversimplification. So if you look at this slide, so this is pooled data from the Religious Order Study and the Memory Ageing Project in the States, looking at a very large cohort of older people who were followed up through the last decade of life, and and then died, and their brains were donated for neuropathology. And what you've got across the top is the results of the final clinical assessment before death. And they were divided up into three groups. Those who clearly, at the final cognitive impairment during the period of follow-up before they died, had no cognitive impairment, those who filled criteria for mild cognitive impairment, and those who filled criteria for what they've called probable Alzheimer's disease. And then the brains were examined. And what you can see is that what we call Alzheimer's disease is almost never due to pure Alzheimer's pathology in this group of people who are generally in their 80s and 90s, which is actually most people with dementia. And in fact, the only thing that really correlates with dementia, if you look at the bottom row, which I've marked up in red, is if you've got a combination of Alzheimer's pathology, so, tau and amyloid and tau pathology, plaques and tangles, plus other degenerative processes like TDP-43 or hippocampal sclerosis, which is a sort of up-and-coming concept, and also the presence of vascular disease. So you really need to generate clinical expression of dementia in late life. You really need to have, in most people, in a large proportion of people, several pathologies present and probably interacting. So this idea that only 10% of dementia is mixed dementia, I think we need to change. I think this idea of dementia as a monopathological construct is, at least in the older cohort, is becoming rapidly outdated. Now, if you look at the presence of vascular disease in these cohorts, if you look at people with no cognitive impairment, it comes to, if you add it all up down the left-hand column, it comes to about 70%. And if you look at people in the probable Alzheimer column at the end, it's about 90%. So clearly, again, there's vascular disease comes alongside late life dementia. It's part of the story. So what are we talking about when we discuss vascular dementia and vascular cognitive impairment? So this is a complex set of interactions which all hone in on the vasculature in the brain. And in this nice review, which I commend you from Ayada Kohler and colleagues from this year, there's a nice picture there of an artery, and clearly bad things are happening in that artery. But of course, the arterial system in the brain is not one thing. It's made up of small vessels and it's made up of large vessels. And the difference between the cognitive effects of large vessel disease and small vessel disease, that's an important difference, which we'll come on to in a minute. And clearly, there will be a number of factors that weigh into the clinical expression of this process. So there will be risk factors related to lifestyle, some of which I've already mentioned. There will be genetic variants, and so for things like ApoE4 probably do play a role in this. And there'll be other genetic variants, small risk rare variants like CADASIL, which we'll come on to. And then, of course, all of this will interact with other pathologies in the brain, which is not expressed on this particular graphic. And then the consequences of that will be a range of pathological processes, including atrophy, large strokes, and then the small vessel disease, which we see as a white matter, but not exclusively white matter process. And all of that will produce a clinical syndrome. But it's, as you'll see, it's not one clinical syndrome. So broadly speaking, I think it's helpful to divide up vascular cognitive impairment into post-stroke cognitive impairment, and post-stroke is normally large vessel stroke. About 80% of stroke is large vessel stroke. And a vascular cognitive impairment that comes without a recent stroke, which is really a small vessel process. And so if you think of the rule of 80 and 20, okay, so if you look at stroke, 80% of stroke is large vessel and 20% of stroke is lacuna type stroke, so small vessel disease. And if you look at vascular cognitive impairment, it's the other way around. We think about 80% of vascular dementia is small vessel disease, and about 20% of vascular dementia is caused by stroke. And that means that we are dealing with a heterogeneous disorder, which will have a trajectory that looks different depending on what the underlying pathological process is. So if you look at A here, this is someone who's having a number of large vessel strokes. They don't project very well, but there's if you look at I can tell you that there's one in the right ACA territory and so on and so forth. There's a number of large vessel strokes on that scan, and that person would present with a kind of a classical stepwise progression. Each stroke is affecting eloquent territory, and you get a cognitive decline associated with that. Then you can have in B people who have a small strategic infarct here affecting the thalamus, which will cause an immediate decline in cognition related to the impact on cognitive pathways, after which you might get some at least partial recovery. And then in C you see the typical leukaryosis of advanced small vessel disease, which produces a smooth decline, not a stepwise decline, a smooth decline in cognition, and we'll come to define what that looks like in a minute. So this thing about where people say, vascular dementia is a stepwise disorder, it's not. Okay, it may be in people who are having successive large vessel strokes, but otherwise it's not a stepwise process in the majority of patients. Okay, now how do you develop an operating diagnostic criteria for vascular dementia? So there's at least three kind of organisations have had a go, and Eric Smith summarised them nicely here in his review. And I think we're going to start to get into some of the difficulties now, which is that we've got to define a set of clinical parameters that distinguish vascular cognitive impairment from other types of dementia. And not all of these criteria really do that, but the Vascular Society have had a go. So it says, if you look here, it says cognitive decline in speed of information processing, complex attention, or frontal executive functions. And that may then be accompanied by some motor or bladder features. So there is an attempt in some of these criteria to tease out what is the clinical syndrome of vascular dementia. In what way might it be different, for example, at a clinical level from Alzheimer's disease? Of course, one of the problems is that Alzheimer's disease can also affect some of the functions that are described there, but perhaps with less weighting and more weighting on memory and visuospatial function. And then the other thing which is important is about whether you're going to require neuroimaging evidence. So are you going to insist, to make a diagnosis of vascular dementia, are you going to insist that there is scan evidence of vascular disease? And if so, how much? And I don't think we really know the answer to that. And this makes diagnosis very complex. So this is some data. I just sprung upon this last night. And this is from Brains for Dementia Research, which is a big programme that many of you might have been involved with. And these are brains that went to the King's College Hospital Brain Bank. And if you look here, and it's a relatively small cohort, but I think it's still instructive, that if you look at the clinical diagnosis of what was called cerebro-vascular disease, which is, it's the second line. It's the second line down there. So people who did brain donation and had a clinical diagnosis of cerebrovascular disease, only 1 in 10 of those brains actually had a pure vascular dementia. So what we're labelling as vascular dementia is it turns out it probably isn't usually that at all. It's something else. So I think this shows some of the complexity of making this diagnosis. So the most recent attempt, I think, again, a consensus attempt, but I think it's problematic. So if we look at this definition of major VCI, i.e. vascular dementia, clinically significant deficits of sufficient severity in at least one cognitive domain and severe disruption to ADLs, And the core domains for cognitive assessment should include executive function, attention, memory, language, and visuospatial function. How is that different from Alzheimer's disease? That's what Alzheimer's disease looks like. So I think we're still struggling here to define a core sort of concept of what VCI actually is. It is the case that MRI is to decide whether there is clinically relevant vascular disease in the brain. MRI is a bit better than CT, and the NICE clinical guideline from 2018 reflects that. Now, in terms of post-stroke dementia, that is defined as a cognitive decline that begins within 6 months of a stroke, either immediately on receipt of the stroke, if you like, or after a delay, but within 6 months, and does not reverse. And so the consensus group tried to sort of produce this kind of classification scheme, which takes out post-stroke dementia on one side, has the various more sort of progressive types of dementia on the other side, and then allows for the interaction with other types of neuropathology. So I think although I think in terms of working criteria, operating criteria, I think we're still lacking, at least in terms of a nosology. I think they're beginning to reflect some of the heterogeneity in this population. In terms of those cognitive domains which are suggested to be relevant to vascular dementia, like complex attention, for example, you might well ask, well, what sort of cognitive assessment should we do to decide that someone is fulfilling criteria for vascular dementia? And so this was, again, a consensus study asking people, if you had 60 minutes or if you had 30 minutes with a patient, and I can tell you, to have 30 minutes to do cognitive assessment on a patient is beyond most clinical assessments. It's only really neuropsychologists who get anything more than about 10 minutes. So, but this is the proportion of respondents who said that they would use these tests. So there does seem to be a pretty good consensus that you should at least test semantic fluency in your patients if you're worried they might have vascular dementia, and a reasonably high consensus around some other things that are listed there. Note that the MMSE is still endorsed by 75% of respondents. Now let's talk a little bit about post-stroke dementia. So how likely are you to get dementia after a stroke? So it rather depends on how severe your stroke is, unsurprisingly. So if you have a severe stroke, so an NIHSS score of over 10, you've got a 20% chance of getting dementia. If you have a TIA, so a short-lived vascular event, it's only 5%. Pre-event. So there's an existing rate of dementia pre-stroke, which is higher in people who go on to have a severe stroke than in people who've had a TIA. Apologies. And if you then come back 1 year later after a stroke, you'll again see that there's an increased accumulation of new dementia in people who've had a severe stroke. It's about a third, compared to about 8% of people who've had minor strokes and 5% of TIAs. And the effect of that, compared to the background population, is to bring forward the clinical expression of dementia by about 25 years for a severe stroke, 4 years for a minor stroke, and 2 years for a TIA. And in a way, these kind of data are not dissimilar from some of the data that Neeraj was talking about with TBI. Here's an example of a strategic infarct affecting the basal ganglia and the thalamus, and this person, as presented in the vignette, had a single lesion, but has developed quite a severe cognitive deficit from that. Of course, I think one of the interesting questions is if you have some underlying vascular disease already, or some underlying neuropathology like an preclinical Alzheimer's pattern, you're probably more likely to get clinical expression of a lesion like that. And in terms of the assessment of post-stroke dementia, it can be tricky because up to 20% of hospitalised stroke patients have delirium. As you will know, depression and fatigue are common after stroke and can mimic cognitive decline. And that's why it's felt that it's best to wait for 6 months until doing your assessment. I'll skip over the exact assessments, but the slides will be available. And this is just some large-scale work looking at the effects of stroke on cognitive trajectories. And I think what's particularly relevant here is the bottom right quadrant, which is, again, looking at animal fluency, so a category fluency task, showing that after a stroke there seems to be a progressive decline, whereas some of these other cognitive domains remain rather stable. So I can't conclude this talk without talking about subcortical small vessel disease, because this is the commonest cause of vascular cognitive impairment. And it's a process that's associated with a range of neuropathological and imaging changes in the white matter and in the deep grey structure, so lacuna infarcts, white matter hyperintensities, leukoiosis, and microhemorrhages. We also think that cortical microinfarcts are probably a significant contributor also to the clinical syndrome, but hard to spot on current MRI techniques. And the clinical features, so again, if how might we define this? And again, it's all based really on a sort of clinical impression. It's all pattern recognition. So insidious onset of impaired attention, cognitive slowing, apathy, a dysexecutive syndrome. Memory can be normal or characterised by impaired retrieval with preserved retention, as you'd expect from predominantly executive disorder. And a range of motor features, including gait dyspraxia and Parkinsonism. And I've already commented that this so-called stepwise progression is in fact rare in this disorder. And we know that depression and apathy are more common in vascular dementia than in Alzheimer's disease, and delusions and hallucinations are less common. And then this problem with imaging. So we don't actually have a consensus on how much vascular disease needs to be present in the brain for you as a clinician to say, well, that's relevant. That's actually the cause of the dementia. Some authors propose a minimum threshold of 25% of the total white matter. Okay, but radiologists don't tell you what the percentage of affected white matter is when they write the report. And so I think there are some difficulties which I've expressed here. It may be that it's more about the location of infarcts and the disruption of networks. And so there's still a lot of work to do to operationalise and understanding the strategic effects of focal infarction into clinical diagnostic criteria. This, again, is a scan looking at a typical sort of small vessel disease scan. Now, of course, there's a whole range of rarer causes of VCID, but the only one I really want to spend more than about 1 second on is CADASIL, which is the commonest of these. And the reason is that it does pop up in clinical practice. It's not completely rare. So it's caused by autosomal dominant mutations in Notch3, which is a gene that's only expressed in vascular smooth muscle cells. So this is a kind of smooth muscle vasculopathy, an arteriopathy. The mutations cause damage to the small arteries in the brain, and they effectively produce subcortical ischemia. And if you look at an MRI scan of someone with CADASIL, you will see a lot, as I'll show you, a lot of white matter hyperintensities. You'll see a lot of lacuna disease, but the distribution is a little bit different to sporadic small vessel disease. And the mutation prevalence has been measured in the west of Scotland, and it's about 1 per 100,000, so 1 per 10,000. And the disease prevalence is about half that. So this is a scan from one of my CADASIL patients. This chap was in his 60s. And what's important about this in terms of the location of the lesions is that you see temporal pole white matter hyperintensities, you see external capsular involvement. So you see a slightly different distribution from sporadic small vessel disease. And what you see is particularly how severe it is. If you scan someone in their 60s and they've got that amount of white matter disease, you should be asking why. And so if you look at the typical clinical profile of CADASIL, it's a disorder of migraine, stroke, and dementia. And this is the fundamental triad. So migraine with aura in young adult life, TIA and lacuna stroke in early middle age, and vascular cognitive disorder from late middle age onwards. And the vast majority of people with a mutation will have detectable impairments in attention and executive function by the age of 50. 2/3 have dementia by the age of 65. And of relevance to this audience, there are high rates of major depression and bipolar disorder in CADASIL. And the median age of death is 70 for women and 64 for men. So it is a life-shortening disease. Now, very, very quickly about the treatment of post-stroke dementia, treat depression and then offer cognitive rehabilitation. And if you think there's comorbid Alzheimer's disease or alpha-synucleinopathy, offer a cholinesterase inhibitor. So that's it. What about the vascular risk factor modification to prevent post-stroke dementia? So unfortunately, I've just listed a couple of big studies there. There is no evidence after an incident stroke that if you then go on and offer very intensive blood pressure lowering, that you can reduce the risk of incident dementia. So that unfortunately is unproven at the moment. There is some evidence that this process, that suppressing blood pressure might affect the growth of white matter hyperintensity. So if you start off with a high burden of those, you don't grow them quite so much if you really suppress blood pressure. What the clinical correlate of that is, I think, remains uncertain. In general, the evidence that suppressing blood pressure aggressively will reduce your dementia risk remains quite mixed. There are small effect sizes in a couple of studies, but also a lot of other studies that have not shown anything. And the most recent update to this is a SPRINT MIND study, which was published in JAMA early this year. And the take-home message from this very large study is that if you suppress blood pressure aggressively in people, to the extent that you can start to show fewer vascular events like strokes and heart attacks, what happens is that you may slightly reduce the risk of MCI over that time period. So you might stop people going from normal cognition to mild cognitive impairment, but the rate of dementia accumulation is not affected. So using vascular risk modification to reduce dementia probably requires lots of time, not the 5 years, the 3 years of treatment and the 5 years of follow-up in this study, and that's a very long study. So although we talk about what's good for your heart is good for your brain, that's true, but it requires years, possibly decades of intervention to have a difference. Okay, I won't talk about lifestyle. So in summary, individual dementia risk is falling, and indeed stroke incidence is probably falling in high-income countries. But unfortunately, and we think this might have something to do with vascular risk factor modification, but unfortunately, vascular risk factors are becoming more prevalent in our society, and that's going to be very problematic. Dementia, of course, remains common in older people and is therefore commonly present on the stroke unit. If you get a stroke, it will increase your risk of getting dementia, and your risk will depend on how severe your stroke is. And it will then set up progressive decline in some cognitive domains. Vascular disease is present in the brain in about 70% of older people who don't have dementia, and about 90% of those who do. So it's very clearly an almost ubiquitous process, but it does correlate with dementia in general. And most vascular dementia is due to small vessel disease, which has specific and clinical specific clinical imaging features that help distinguish it from Alzheimer's disease. But I think there's still a difficulty. I think our operating criteria are not good enough yet to say that we can reliably say on clinical grounds who's got what, and of course that is reflected in misdiagnosis, which is then discovered at post-mortem. In terms of treatment, I've just summarised there some of what I would have said, but essentially you can probably over many years start about 3 to 5 years of high intensity blood pressure treatment, reduce the number of people who get MCI. That to show that yet in that time frame that you've reduced dementia incidence is not yet proven. It will probably take a long time. It's a very slow process. So those are my disclosures. Thank you for your attention.